I will present myself. I'm a cardiovascular surgeon in France, still practicing, despite my age. And I'm very interested in the prevention of cardiovascular disease. And the institute I founded several decades ago is about this aim: prevent cardiovascular disease. Is it possible by drugs, diet, exercise? Big topics. So my presentation is about the comprehension, the problem of atheroma. You know that atheroma is a very prevalent disease in the European and industrialized populations, and we don't know very well how this disease evolved, and we usually know the late stages of the disease. So we will speak about atheroma, sad fats, and palm oil. What are cardiovascular disease? It's important to tell you what are they mainly. Mainly they are stroke, as you see, and heart disease. Other diseases are minor. So our topic is about stroke, coronary heart disease, and PAD, which is peripheral arterial disease. All these diseases are caused by atheroma inside the wall of arteries. Atheroma is usually known as an aging process, but we are not sure of that. Chronic disease, cardiovascular disease, are very underestimated. You can look at this slide and you see that heart attacks, stroke are at the tip of the iceberg. But a lot of people are at risk in our populations. And we have only very restricted markers to identify those patients. And cholesterol is a very poor marker. So, what is the present framework of atheroma? What can we say about that? The first thing is that from diet to coronary heart disease, there are a lot of environmental factors and a complex genomics which transform your diet in good health or risk diet. Whatever the diet is, you know. Some patients do not smoke and do have some coronary artery disease or stroke, okay? Usually, smokers has a very high rate of cardiovascular disease, but it is a complex, multifactorial, and polygenic disease. The second point is that atheromatous plaque is an inflammatory lesion. You see here, you see here the lumen is the laser one is which one? Là, ok.
Non, là, vous avez arrêté. Là, c'est à droite pour faire avancer et à gauche pour...
Non, mais le laser, il est là.
Le laser, il faut appuyer. Voilà.
Excuse me, please. Here is the lumen of the artery. Here you can see that the lining of the artery and the smooth cells, and in this space you can see an inflammatory lesion with mononuclear cells and all the mediators which are present to create an inflammatory lesion. This lesion is the explanation of the growth of the plaque. So atheroma is basically a low inflammatory state. If you have no inflammatory state, you will have a very low prevalence of atheroma on the arterial tree, and above all, the complications will be very few. this lesion leads to emboli, and you can see here a thrombus which will emboli in the lumen. The lumen is here, so the artery is here, like that. And this emboli can create a thrombosis of the vessel, occluded the vessel, or it can create an emboli in the brain, and it is a stroke. So from the inflammatory lesion to the complications, this plaque is a complex lesion where you can find inflammatory cells, and growing of this plaque will escalate to the complication thrombosis and emboli. This is a plaque. You can see here a carotid bifurcation. This is located here, usually, here on the both sides. And this is a plaque here with a plaque hemorrhage. The plaque is quite completely occluding the vessel, above 90% stenosis, and the blood cannot go very easily to the brain. The brain is here, and the heart is here. This person is a woman. She did a stroke on tobacco, pill, and some genomic factors. So you can see this lesion because it's very interesting to look at this and to understand that atheroma is a very late stage when you are operating on this kind of patient, because this plaque is about 10 years of implementation, formation, growth, and so on. So another time, chronic inflammation, low-grade inflammation, and risk and multiple risk factors lead to this kind of lesion. The role of inflammation is very easily understood on this slide. When you have a low CRP, CRP is a marker of inflammation, and a low LDL cholesterol, you have very few probability of heart disease. If you have a high CRP, so high inflammatory level, and a high LDL cholesterol, you have a lot of events in the field of coronary artery disease. And the mix is interesting because when you have a high CRP and a low LDL cholesterol, and we see a lot of patients who haven't any elevated LDL cholesterol and who do an infarction, a myocardial infarction, and the explanation is that they have other factors and especially a high CRP. Okay, after atheroma, we look at saturated fat. Saturated fat were demonized by Ansel Case on this graph. The problem is, and I will not be very long on that, but we will discuss that perhaps after, but the problem is that all these countries here, with the percentage of diet of saturated fat in the intake, and there the incidence of coronary artery disease, some countries are not in the graph. That's a problem. The second point is that the retrieval of information, the data were not so accurate than we can have now in nutritional studies. So this graph, which is the basis of all the policies of low-fat policies and so on, and the demonizing of saturated fat was in fact wrong. Why? Because we have this meta-analysis. Siritarino did it in, 2010. Okay, so it's not recent, but it's very recent. You see there that as for cardiovascular disease, stroke, we haven't any effect of saturated fat, which is significant in all these studies. So saturated fat are not linked to stroke or other coronary heart disease. And at all, in the total here, you can see that the effect is neutral. So all we have said about saturated fat should be rethought, at least. What about palm oil? Is palm oil heterogeneous? Is palm oil a culprit in cardiovascular disease? This slide shows you that when you look at butter, palm oil or coconut, meat and dairy, you have a very few increase of the risk. The most important increase is with meat, saturated fat. The surprise is, we spoke about this together, is that dairy decreases the risk of heart disease and the cardiovascular risk. And so butter is neutral, and plant saturated fat neutral too. So this study in 2012 showed us that saturated fat are not equal, but it is difficult to incriminate palm oil on this on the basis of scientific results in studies. Is there any explanation of the precedent data? Perhaps in dairy, you look at this composition of fatty acids. You can see here that dairy products and dairy and milk and so on has a lot of this kind of fatty acids, which are not present in meat. Perhaps it's an explanation. And we had in the past look at the myristic acid. I heard about your question. Perhaps here you said myristic fatty acid are bad, but it's very controversial. And especially the myristoylation could lead to a decrease of the risk. What happens when we substitute palm oil? If palm oil is bad, we can try to substitute. What happens? If we substitute for trans fat, the game is over. The risk is escalating a lot. So please, I think the honor of industry is to make products without trans fat. It's my view, and it's based on a very, very important studies, numerous studies, and I think the game is over. Here, when you substitute with mono or polyunsaturated fats, you see that it takes a lot of substitution in terms of the quantity of energy you have in your intake to diminish slightly the risk. Here you can see another point about the deterioration of the lipid profile with trans fat. This is very well documented, and I'm not a fan of lipid profiles, but in this case, the deterioration is very obvious. So trans fat increase the risk of coronary heart disease, perhaps cancer, and deteriorate your lipid profile. What is the level of evidence? The level of evidence is there. The pooled prospective and retrospective studies shows that the increase of risk is significant, and it is 30%. But in some studies, it's very high, like here. So For trans fat, we have a lot of data. What about substitution by oils with a high concentration of omega-6 Q fat? You know that omega-6 are unstable. They can be oxidized very easily. So when you oxidize, I spoke about that at the beginning of the presentation, atheroma is a low inflammation process. So if you go in this way with an increase of oxidized LDL, which are here, you will increase the inflammatory level and state. So it's not so good. And the data are in favor of this deterioration. You know, when you selectively substitute LA in PUFA interventions, you favor control. Not very good. When you mix omega-3 and omega-6 in the PUFA interventions, you have a slight beneficial effect, but it's not significant, as you see here, because it touched the line here. So it's not significant, but a trend with a favorable effect. And overall, if you mix the different PUFA, it's neutral. So now substitution with carbs. Very interesting. If you use carbs, you will have a very mix of high GI and low GI carbs. What does it mean? When you substitute here dietary carbohydrates for the baseline diet, if you increase the presence of carbohydrates, you deteriorate the profile of your LDL particles. And this is very important because LDL particles are the culprits if they are small and dense here, not if they are large and buoyant. In arterial wall of atheromatous arteries, we find small LDL oxidized and dense. So when you substitute with carbs, you deteriorate the profile of your LDL. Not so good. Okay? And when we substitute with this in this study, either PUFA, we said it, little benefit. When we substitute with carbs, no benefits, we deteriorate the product. And when we substitute with olive oil, it's very surprising. There are not a lot of studies, but it's not so good as we used to say in the media and in the different studies, because med diet is not based on olive oil only. So my conclusions are: first, it's not only a matter of calories. That's pretty evident now. You see here, fat is decreasing, carbs increasing, and then from 1971 to 2000, obesity increased here. So it's not fact. Secondly, since 2000, oil is quite stable, especially fat. Carbohydrates slightly diminish. The set fat is quite stable, and we see this. We continue to have an increasing of obesity. So we have to question the conventional model. Because essentially, the framework of CVD is this one. Smoking, sedentarity, central obesity are the main determinants of atheroma here. And this central obesity is caused by excess of calories, but also mainly by insulin resistance. And insulin resistance is depending on fast and very rapid sugars. this is the factory of low inflammatory states in your body, central obesity. So palm oil is about 8 to 10% of sat fat in the French people intake. Animal fat is 85%. As you can see, I think it's not a significant factor of cardiovascular disease. We haven't any scientific proofs of that. We have to improve now our cardiovascular mortality by other means, but for patients with high intake of sat fats and high risk of cardiovascular disease, diabetes, patients with a familial history, we should look at the sat fat because they eat usually a lot of sugars, starches, right, and then cheeses or meat or fatty meats, and they have to shift to less sugars and to cut the fatty meats for lean meat. For instance, the mortality rate of CVD in the European Union is now very low in some countries, France, but in all the countries it has decreased since the last Second World War. So it's a big trend which is explained by other factors than the diminution of sat fats, because sat fats has not diminished in our consumption, and French used to eat a lot of sat fats, as you know. So we eat a lot of sat fats, especially dairy fats, and we have a very low mortality rate of CVD. I will go to the last conclusion. If we want to sum the different rules and the different fats, I have the 6S. You know that there is a 4S statin trial, but I would like to emphasize that my rule of 6S is better. Because you can quit smoking, sitting, and sugar. That's very interesting. In your work, don't sit, don't smoke. Quit sugar at the different place where you eat this fast and rapid carbs. Check your scale because it's the sum of calories in, calories out. Check your salt, especially if you have a little hypertension, and check your stress. Thank you very much.